Okay, good afternoon, good morning, good evening, everyone. You are all welcome to the PAPERI webinar series. I'm Jacob. I'll be your moderator today. Thank you for joining us for our session on economic and genomic synergies for advancing pediatric cancer care in low and middle income countries. I am delighted to introduce our esteemed speaker, Dr. Nickhill Bhakta. Dr. Bhakta is an associate member in the Department of Global Pediatric Medicine at St. Jude's Children's Research Hospital. Within the St. Jude's Global Program, Dr. Bhakta served as the regional
I think I can't hear. You hear?
Okay.
Okay.
Director of the South Program. Hello?
Yes.
Hello, can you hear me?
We lost you for a moment, Jacob.
Yes, now we can hear you. You stopped at Dr. Bhakta serves as the Regional Director of the Sub-Saharan Africa Program.
Hello. Can you hear me?
Is there a problem, Jacob?
Yeah, hello.
Yes.
You can hear me now?
Yes, please. Continue. Yes.
Okay. Right. So Dr. Bhakta serves as the Regional Director of Sub-Saharan African Program, where he coordinates capacity building initiatives. Additionally, as the Director of the Disease Burden and Simulation Unit, Dr. Bhakta also runs an epidemiology and health economics research program focusing on global disease burden, multi-mobility research, and cost effectiveness. Core collaborations include steering programs with colleagues at the International Agency for Research on Cancer, the Institute for Health Metrics and Evaluation, and the Concord program. His other primary implementation roles at St. Jude include leading the cloud-based hospital-based cancer registry network among over 20 countries globally, coordinating the area guide adapted management guideline initiatives and the DIV program, a novel cloud-based next generation sequencing and analytic clinical platform currently under development. He's a native of the Chattanooga, Tennessee. Dr. Bhakta earns his bachelor's degree with honors in history from Brown University, a medical degree from the University of Cincinnati College of Medicine, and a master's in public health from the Harvard School of Public Health. Before joining the faculty, Dr. Bhakta joined St. Jude's in 2013 as a clinical fellow in pediatric hematology and oncology. He currently practices clinically within the division of leukemia and lymphoma. This seminar will discover how economic strategies and genomic research are shaping the future of equitable healthcare. Please join me welcome Dr. Bhakta. So to ensure that the meeting is smoothly run, we will like to say that we'll have a Q&A session at the end of the meeting. So if you have a question, you can type them in the chat, and then we'll read them after Dr. Bhakta's presentation. Otherwise, when he is done, you can unmute your microphone and raise your hand, and then you will speak. The meeting will be recorded and will be hosted on our YouTube channel. Thank you very much. And Dr. Bhakta, you are welcome to PAPERI, and the floor is yours. Thank you.
Thank you so much, Jacob, and thank you so much to the organizers for allowing me to present. Can you see my slides?
Yes, please. We can see your slides.
Okay, perfect. I don't know why I won't. Hold on one second. Let me just reshare this because it's being a little bit. Okay. So again, thank you so much for letting me present. This is I'm really excited. As was already said, so I'm a little different than I think many of the probably molecular pathologists, the molecular genomics folks that are usually presenting to you. I come to this field actually as more from a health economics epidemiology angle, both because of my role as a person who works within the health economic space, but also because I work within Sub-Saharan Africa. And many of my colleagues who are in the region, this is actually a major issue. So we all know some of the challenges that we face from a diagnostic standpoint. Every Friday morning, so actually right about this time, we run a case conference with colleagues from about 12 different countries. About 400 people join on average. And we have cases of childhood cancer that presented from all over the region about how to manage, what are the issues. But one of the most recurrent themes is about, well, what is the actual diagnosis for the child that has come in? And a lot of times we're scratching our heads, we're trying to figure it out. And this has been an issue that's been going on for not just 1 year, for 10 years, but for 40 or 50 years. And we're living in the moment of this massive genomic race that's been occurring mostly in high-income countries in the United States and Europe. But we're not seeing it trickle down into the everyday life and clinical work of colleagues all throughout the world. And so really what led me into this space was thinking about what are those barriers. And of course, one of the major ones, but not the only one, is cost. And so I'll walk you through some of the thinking that we've had, some of the costing work that we've had, and hopefully you can understand a little bit about the policy implications of this work as well. So go ahead and start. I have no major disclosures. I think everybody probably on this call is familiar with the Global Initiative for Childhood Cancer. And that was an initiative that is a WHO-led initiative together with St. Jude as the primary implementation partner, launched about 6 years ago at the UN General Assembly. And it was a call for all countries in the world to start to recognize that childhood cancer was a major issue that merited and deserved increased attention, and from both a policy and an implementation angle. So together with the WHO, we came up with these targets of improving survival by about 50% to over 60%, which would be a doubling of the current, or at least the 2015 goals, or at least what we saw, and improving outcomes for about 1 million children. And with that, we created technical packages, which included questions about how to improve access to care, and of course, diagnostics are a key component of that. But what is the standing, or where do we stand globally? Well, first of all, we know there's a global survival gap. So the figure up on the top left there really highlights what we understand as the best, and this is modeled data, so it's not certainly observed in every setting. But we see that the red is poor survival, green is our best achievable survival, and most of Africa and parts of Asia we have really poor outcomes for the most part, and that's a true challenge and a huge disparity, and really represents one of the largest disparities in all of global health. The fact that over 80% of children in the United States, Europe, and Australia survive their disease, but probably less than 20% in many parts of Africa survive their disease as well. Compounding this fact is that we have not just only a survival gap, but we also have a diagnostic gap. So that we estimate that about 400,000 children develop cancer every year. Only about 200,000 of those children are actually diagnosed. And even among those that are diagnosed, data from Uganda and many other countries have now shown that potentially up to 1/3 of those children who are diagnosed get an incorrect diagnosis. So when you think about that, probably about 125, 150,000 children get a correct diagnosis, meaning that there's a gap there of about 250 to 275,000 children that have a wrong diagnosis. And that means that that's about 250,000 children every year that will die from their disease, because not being diagnosed or getting a wrong diagnosis and getting the incorrect therapy ultimately likely will result in mortality. So what is the current lay of the land of how do we understand that major gap in diagnostics? And so if you look at just diagnostics, standard diagnostics for something like leukemia, this is actually now a little bit dated because we have over 200 hospitals worth of information. But when we look at, for example, just access to morphology, universally, most hospitals around the world that we work with that treat children with cancer have access to a basic blood smear and a basic ability to review a bone marrow. But advanced diagnostics or intermediately advanced diagnostics, such as flow cytometry, FISH, karyotype, molecular studies such as PCRs, you can see that at low-income and low-middle-income countries where the vast majority of children diagnosed live, the reality is that access to these diagnostic modalities are minimal and spartan. So as a result, we can continue to think, oh, well, we just need to improve capacity for standard of care and these kind of diagnostics. And that has been our way of thinking for the last 40 years. But I always like to talk about the fact that 40 years ago, well, no, actually, yeah, over 40 years ago at St. Jude, 45 years ago, the first immunophenotyping of leukemia was done. So Tom Look, who's now at Harvard, who's a pretty famous biologist, he actually developed as a fellow at St. Jude flow cytometry and immunophenotyping for ALL. And so we look back, and as an institution, we often refer to that as one of our institutional achievements. But it always frustrates me that just last week I get a call from colleagues from the continent telling me, we really would love your help to set up flow cytometry. It's 40 years plus now since we've developed that tool, and we still have not implemented it. So we can spend another 40 years talking about how we need to do it, or we could think about new novel ways and start to understand why have we failed over the past 40 years to achieve those goals. And so I think that this is where we have the opportunity for molecular diagnostics. And so and we'll get into more details about why I think this is an opportunity, but I'm sure many of you already understand these, so I'm not going to bore you with those details. But we had to really rethink our approach and understand how can we do this in a way that can be scaled and can be done in an efficient way. And so we always know that like a lot of times people are shipping samples to the US, shipping samples to the Europe, mostly for the purposes of research studies. But it's time to stop thinking about that idea of shipping samples. It's time to start thinking about how can we actually do sequencing locally, and how can we perform analyses rather than, again, the excuse for shipping samples is, well, I can run it through my pipeline. Well, our banks all sit on the cloud. All of this right now, this presentation is sitting on a Microsoft server somewhere. We can do data analyses in a cloud computing environment. So why not just set up a cloud computing environment, have individuals upload that data, run against standardized classifiers that can be readily updated, and as technology continues to improve and informatics continues to improve, and our understanding of the biology of cancer continues to improve. And then have those results returned back to clinical pathologists, wherever they may be, and train them through using mechanisms that we've implemented already through St. Jude and others. But also, for the first time, actually create a true database for translational research. And this would allow for us to, in a federated manner, aggregate all of those genomes and create a resource for the global community to be able to study childhood cancer at a broader level. And so this figure doesn't require any introduction, I'm sure, to the groups on this here, which is the fact that over 80% of the genomes that are currently in most of the global repositories come from Northern European populations. And so it's often that we'll lament on a regular basis, how can we have such poor representation in our genomics? We need to do better about having increased representation. Well, we talk about it and people will publish about it, but what are we doing about it? And so that's what we're trying to think about here, is that if we can decouple this barrier between research and clinical and actually think about research as being secondary research off of clinical samples and make genomics and genomic testing through next generation sequencing affordable, we can actually start to reduce this gap and chip away at this, because then we'll be producing data sets as part of the standard clinical care and not as external research studies. But we know that this has not happened, right? So we know that there are major issues and barriers to doing this. So if you think about genomic data and getting clinical data, what needs to happen to pull that information together? Well, first of all, we obviously have technical barriers. So do you have a Illumina platform or other types of sequencing-based tools available? Do you know how is your team competent at producing quality data? I know that during COVID in the early years, 50% of the genomes uploaded into the CHAN database were actually unusable due to poor quality. So how do we ensure that the technical components about all of this are met? And then, of course, it's not just about having the sequencing, it's also about having the pipelines and the informatics available. So do we have the right classifiers? Do they meet the standard? What is good enough? What is, if a classifier is 95% correct and the standard of care with morphology is 50%, and we'll get into this again a little bit more later, what is that good enough, or does that have to be 100%? And what is the, do we need to be as good as the gold standard at St. Jude, or does moving the needle a little bit actually improve things? And so that's reasonable to start with. Computing. Of course, not everybody has a high performance on-premises high computing cluster that they can just submit their jobs to. So what are the opportunities in being able to do that? And then, of course, automation. And I don't mean that just in the lab. I mean that also on the analytics side. So many people will upload their data and spend how many hours curating each sample or each data set in order to be able to run through the pipeline. And of course, that's not feasible or cost effective as well. So really what we've thought about is utilizing platforms like AWS or others in a multi-cloud fashion, creating a cloud platform, both as a data repository and an analytic platform, to do that, link it to that return of results and federated database. And of course, we know many of our colleagues are interested about how to link these. And so figuring out ways upfront to how to create the data system so that they could be linked to population registries, hospital registries, or other different sources of tools out there that may be available. And of course, we have to think about how to train this workforce, so that has to be a part of the conversation as well. And so, we know that there's many different types of strategies that one could use here as well. So this is not going to be a one-size-fits-all. There's RNA-seq for solid tumors, for leukemias. There's adaptive sequencing now for leukemias, and I'll go through some of these a little bit later. DNA methylation for CNS tumors has really been, I think, one of the early adopters out there. But remember, the way that people are doing DNA methylation in CNS tumors is, at least on the pediatric side, is they're sequencing locally, or sometimes shipping the samples to Germany, but now sequencing locally and uploading into a database run by an institute in Germany. But if you read on there, that classifier and that system is for research only. So we're still not creating clinically valid or clinically viable tools that are out there, so that way you can link that. Is because, yes, an individual hospital, an individual clinician can have their data sequenced on a patient and upload it, and depending on the strength of your local ethics and local regulatory systems, have that research tool being able to use for clinic, which is technically not allowed, but certainly is the norm for many people. Or we could actually set up these systems to be clinically valid and then actually play a role in the policy debate and try to then say, well, this is a clinically appropriate test. We should be thinking about how to finance that at a local and a governmental level, and then no longer have this hiding in the shadow. So that's the problem with some of these research-based approaches. And then, of course, DNA sequencing for CNS tumors, people have been exploring that. So, for example, there's been some interesting work out of Princess Maxima, actually having intraoperative DNA sequencing with adaptive sequencing for CNS tumors actually they did not do adaptive, but shallow DNA sequencing to be able to make a diagnosis off of methylation calling from nanopore. So that brings us to not only are there trade-offs in the type of sequencing approach that you have to think of, and all of these have cost implications, there's also what technology platform you use. And I'll give you some data on this in a moment. But of course, Illumina is the gold standard. Most people think about this as the way that we would want to do that. And at St. Jude, this is what we've implemented clinically. We use RNA-seq-based transcriptomics, and then use and analytic backends in order to be able to analyze ALL. We also use epic arrays for CNS tumors in order to be able to make classifications. So, I mean, Illumina has become at least the clinical gold standard in the cancer space, but has significant challenges with costs. Where there's also Oxford Nanopore, and there's many other emerging technologies, but I think of these two as having the largest global penetration. There's like PacBio and all these others as well. But Nanopore is really interesting because it has a globally installed base because of its use in infectious disease and agricultural research, and it can be low throughput. You can because of the long-read sequencing-based approaches, it actually gives you opportunities to really go at shallow sequencing and still get clinically viable responses from the samples that you get. And of course, it's very low capital costs, so that makes it very easy to implement. And you can wash the flow cell, so you don't have to necessarily, with Illumina, you have to multiplex multiple samples at a time and the more that you do, the more cost effective it is. But of course, childhood cancer is rare, and you need to have a quick turnaround. And sometimes you only have 7 days for an ALL case when you have to make critical decisions. So you're not going to get 15, 20 samples in that period of time. Whereas with Nanopore, you can run it, wash the flow cell, reuse the flow cells as well. So there's multiple examples out there, I think, in the literature, and many of you probably have seen them about Illumina-based classification examples. These are just 4 that I pulled out there for ALL that are being used, and I think you can see that they all meet different levels of accuracy, and most are based off of gene expression patterns. There's now multimodal ones that are coming out, which not only are gene expression, but incorporate direct fusion calling, that incorporate CNV files all through transcriptomics. So that way you basically upload a transcriptomic file and then analyze it in different ways to look for fusions, to look for your copy number variations, to be able to do your gene expression, and then aggregate that information together in order to be able to come up with a classification. And then, of course, there's Illumina DNA methylation, which is being used for CNS tumors. And as I said, there's already work being done in Germany on that. St. Jude, we have a DNA methylation classifier that we use for our clinical trials. That's IDE approved from the FDA. And it works really well. The limitation, of course, is that you're limited by what's in the array. And of course, every time the array updates from 850 to 950, you have to revalidate the test. But these techniques actually have pretty good correlation between gold standard as well as the genomic arrays that are being used. Nanopore as well has pretty good, but has different utilization and may only be useful in certain contexts for certain, at this stage at least. So for example, lineage for ALL, many hospitals, as I said, use just alone morphology. And so that means that you really can't tell whether it's ALL or AML. It's almost a flip of the coin. So we've done this work together with Pakistan, Malawi, India. This has been a multi-site collaborative effort with colleagues at the University of North Carolina and St. Jude. And we published looking at acute leukemia lineage, showing that we can call lineage. So for settings that don't have flow cytometry, this could be an interesting opportunity. It also works well for extracranial solid tumors that we can set thresholds, and it actually makes accurate calls for knowing whether something is rhabdomyosarcoma versus neuroblastoma, and can actually give you some additional information on some of the fusion positive, fusion negative rhabdos as well. This has been funded through NIH work for our collaborative teams, and it's actually we've implemented this relatively well to see that it works well in contexts that don't have access to flow cytometry or reliable immunohistochemistry. And of course, as I'll go through momentarily, the costs are significantly lower than Illumina-based technologies. This is just showing again the ALL and ALL and such, and it also works in like I said, in solid tumors. We've done more now, but this is a publication that came out where we looked at all the tumor types, and depending on where we set the prediction probability of 0.8 or 0.6, we have very high correlation with the diagnosis that was given by traditional methodologies. So just kind of taking a step back, so we've kind of reviewed the global challenges, the renewed interest in global childhood cancer at a global level. We talked a little bit about the fact that there's opportunities to implement next generation sequencing that can really move beyond where we are right now. And then of course, I talked a little bit about the different testing that's available, but where does this fit into that broader diagnostic pathway that we all know? And so if you think about diagnosis of a child with cancer, you often have to think about, and for those of you that are not clinical, you have a patient comes in, I can see what age they have, I can do imaging to see if they have metastatic disease or not. But then I can look under a microscope and look at morphology. But the next thing I want is immunohistochemistry or flow cytometry, depending on the diagnosis. And then I want my macrogenetic information for leukemia. So for example, I want to look at cytogenetics, I want my FISH, I'll look at molecular diagnostics. A lot of people want to look at targeted molecular diagnostics. So they'll do a panel, from Illumina or from Archer or something like that, because it'll be a little bit more parsimonious, because we'll already have some information, and so we're looking for more targeted information. Maybe we'll look at transcriptomics for fusion transcripts or something like that. But as you can imagine, each of these tests continue to increase in costs. And you'll see on the molecular side, it's purposeful that the money signs fall off the page because we can go as high as we want with some of that work. You can do whole genome, you can do whole transcriptome, you can do both, you can do whole exome. At St. Jude, we actually do a triple platform where we would do whole genome, whole exome, and whole transcriptome on every patient twice, both on their germline as well as on their somatic. So you can imagine the costs begin to add up, but you do that mostly for research purposes. And so as we start to think about why do we do this and what does that mean at a global setting, we have to really think about some of the ethics behind the testing selection, as I talked about, and how we balance all of these issues. And we also have to recognize that a lot of the genomic data is being developed in high-income country settings with the purpose of really driving novel subtype and prognostic classification. I think there's a couple of ways to look at this. The optimistic way is to say that we're doing research and trying to understand the biology of cancers to really be able to then help illuminate and identify potential new therapeutic opportunities in the future. The pessimistic way is to say everybody has a research lab and is trying to come up with their own new classifiers, get a new subtype into the WHO Blue Book, and so they want to come up with not clinically relevant subtypes. So it's not about the fusion positive, fusion negative rhabdomyosarcoma, which is important. It's about defining somehow 30 different rhabdomyosarcoma subtypes, of which will have no current mechanism for actually acting on that, but it's good to know. And so that's really where the field is right now. Let's be honest. And the drive, for the most part, is to have that kind of work in high-income country settings. But balance on that is really about clinically relevant diagnostics, where really the pendulum has not really moved. Although we've seen some work in things like cell-free DNA, and that's because that's kind of cutting edge. Just good old basic transcriptomics and trying to utilize some of those mechanisms that can potentially at low cost be practical, hasn't really caught the interest of high-income country settings. And so as a result, there's been this assumption that we develop it in the lab and then don't worry, industry's going to solve it. And the reality is, no, they're not. Childhood cancer is rare. There's relatively little interest from industry to solve this issue because there's a very small market for this. So it's left to ultimately to local academic labs or some private labs that are interested in this from a health equity standpoint. So the global focus has thus far really been on this novel subtype prognostic classification. And we have to ask ourselves, is this really the ethical approach? And how can we start to improve that the balance, and so that we not only are constantly pushing these novel subtypes, but are also thinking about clinically relevant diagnostics at the same point. And of course, we have to think about this in the context of what I do at St. Jude may not necessarily be what is needed in every hospital around the world. Do I need to have whole genome, whole transcriptome and whole exome for every patient twice? No. The reality is that I have access here. First of all, I probably don't need that at St. Jude. We all have to recognize that our clinical pipeline is mostly research anyway. But more importantly, the truth is I also have access to phase 1 trials. I also have access to bone marrow transplant, immunotherapy. I have access to a variety of tools here that are not available globally. So does a site that doesn't have access to bone marrow transplant need all of those, or does it just need to be able to understand who's a low-risk ALL so that I can do my best job to cure what is curable in front of me and not try to get all these fancy tests to be able to apply therapeutics that I won't have access to? So really that is a concept of this equality. I don't need to have the same tests everywhere, but rather equity. I should have the right tests in the right environment. And so what does that mean? What does that look like when we think about, again, thinking more broadly from a policy level? And again, this is taking you out of the lab and helping you, and hopefully helping you think about some of the parameters that as the work that you're doing and your discovery work that you're doing, if you're a basic lab scientist, how you can think about translating that into the real world. And so as you think about the utilization of these diagnostics, right? So on the top here with these figures, you can see what I showed before: histology, immunohistochemistry, flow cytometry, the standard kind of diagnostics here in blue and green that we use for childhood cancer currently, and then access to gene panels, microarrays, and other next generation based tools. And of course, each of these give us different information, right? So the tissue lineage we get from these blue boxes, the green will give us some more core genotype. And then, of course, we use these gene panels, microarrays, again, in a parsimonious way to give us these established secondary alterations. And so, the cost, of course, continues to increase with some of these tests, and the availability in the blue box, on the blue charts shows that access to these continues to decrease over time. And then, of course, there's cost implications, right? So some of the nanopore-based technologies are much cheaper, but may not give you all of the secondary genomic alterations, may give you just tissue lineage and genomic subtyping, but that some of the more expensive ones may give you everything. You could potentially get with RNA-seq not only the lineage, genomic subtype, but also most of the genomic alterations as well. And so one test could potentially give you all of this information, but of course comes with a higher cost. So there's trade-offs that we have to think through. So we have to think about this then in the context of the setting, right? So again, thinking about what does low and middle income country look like, it may be that when we think about the utility of these tools, if you have the ability to treat, having access to an Illumina-based diagnostic may be making sense. If you have already in place IHC flow, karyotype, and implementing this will give you more information. But if you're sitting in most low-income countries, as I showed in that graph, where you only have histology, you don't have access to any of those modern diagnostic tools, even just giving nanopore sequencing, the cheapest one, will still give you a relative advantage, right? So here, the advantage is that beyond FISH, you're getting a little bit more information from your Illumina. With nanopore, even though you're not getting all that information of Illumina, you're still getting more information, and it's much cheaper. So we have to think about how we can balance the context-specific clinical utility, recognizing that you may not have fancy immunotherapy chemotherapy like blinatumomab or inotuzumab or things like that that are just coming now to frontline for ALL in high-income countries. And so we have to think about, is there a way to then utilize a singular test and then de-implement or obviate the need for all of the other testing? Because I think that's really, really the promise of molecular diagnostics, is that, before we've had orthogonal-based testing approaches, which really are about using one test, building on that with another test, building on that with another test. And then by the end, you have to have about 10 different tests for every child with cancer. Each one gives us slightly different information. Each one requires its own supply chain, its own cost, its own technical training, its own validation. But can we remove all of that? Can we envision a future where we have one test, one supply chain, one training, and it just gets run through a pipeline? And not only do you get the information on what that cancer is, you potentially could get pharmacogenomics, you could get pharmacotyping, you could get all kinds of further information as well. So it's one test, multiple uses, not multiple tests for one use. And are there ways that we can save money in the process? Obviously, reducing the cost of some of those tests, but also thinking about ways that we could actually make genomic testing cheaper by having it fit to process. So taking a step back, let's just think about, how do we actually measure costs? And so this is maybe new to some of you who, again, are more laboratory based. There are some concepts that we need to think about. So, and I've said a lot of this already, strategies to expand pathology traditional pathology have really failed over the last 50 years, and next generation sequencing has that potential opportunity. And so we have to make sure that we have guardrails, though, and we have to make sure we have guardrails from a research analytics standpoint on the health economic side, right? So you can make the costs of anything look nice, but you have to think about this not just as numbers for price costing out. We have to think about this about making sure that we're not compromising quality of testing through cost reductions. We have to make sure that the approach that we are putting in place is economically viable, and that it requires, then we have to think about the costs of upfront mitigation and other ways. And so we have to think about all of these concepts of how to sustain it from the very beginning. We have to evaluate all scenarios that are realistic. We can't just think about one scenario and then just stick to that. So that means we have to think about what's coming in the future as well when we do these analyses, because we want to make sure that we invest our research time into things that are worth investing in. And then, of course, this can't be something that's done by only somebody at St. Jude. This usually requires collaborative research. So how do we do this. So, I mean, a lot of times it's about coming up with ingredient lists. So it really is like balancing a checkbook. You have to think about what cancers you actually want to cost out. You have to come up with the ingredient list. So many of you who sit in the lab know what all this is, but you have to think about what reagents do you need, what are the consumable resources, how much time does it take for somebody to run all these tests. So that requires us to actually come up and develop data collection tools, and we've done some of this work already. But just to kind of give you a sense of how costing work is done. We have to have access to the data from countries. We have to know where people are running these tests, who has what access to what tests, and who doesn't have access to tests. Because we know that, as I showed earlier, access to cytogenetics is actually relatively poor in low and middle income countries and low income countries. And then, of course, how much does it cost for each of those? So use surveys from data from centers to be able to collect that information. And then we need to understand how all of this varies from different settings. And so that means that we have to calculate cost specifics in each country. And so this is just an example of, for example, in ALL, here's all the different testing that you need. And then each of these tests, like each of the different ones that you see on here, we need to have micro ingredient and costing for each of them. So fortunately, a lot of them are iterative and it overlaps a lot. But the point is that this is how you do that costing work, is essentially as you would do any budget. You basically break it down into its different pieces and then try to get prices and put those into it. And then, of course, look at how much it costs for the activity of actually doing the testing itself. So to give you some numbers to this was early work that we did from US, Pakistan, and El Salvador that we presented about a little bit ago at SciOp. And we were really wondering, before we start talking about some of the molecular diagnostics, what does access look like in 3 centers in these contexts, and what does the cost of actually doing these diagnostics look like? And so we looked at what is the flow cytometry costs in the US versus Pakistan and El Salvador, and you can see huge variation, less than $200 in Pakistan, but over $1,200 in the US, but it's still $600 per sample in El Salvador. And that's because they have to staff their flow cytometry lab, and they have to buy reagents that expire at very low quantities, and they don't have that many patients. So as a result, it becomes very, very costly. Karyotype, you can see what the costs look like in fish. And regardless, if you look at those individual costs, which are reasonable, and they actually do translate, I think the ones in Pakistan translate to what we see mostly globally, you can still see that you need all of these tests in order to make a comprehensive diagnosis. And even then, they don't have all the fish available. It's still about $700 per patient that they're spending in Pakistan just for an ALL diagnosis. So really, that gives us a framework for, can we do better than that? So as you hear about some of the work coming in the next few slides, that $700 is what we're starting with. Of course, the US is way more expensive, but even in El Salvador, it's around, just with flow cytometry, we're talking about $600. So that $600 to $700 ends up being where we are. And so can we think about these costs, and can we think about costs and what is the baseline, and then how can we start to mitigate these costs? So actually, I'm going to skip to, there's a few numbers that are going to follow, so just bear with me. We're going to plow through this relatively quickly, but I want you to get a sense of some of what things cost right now based on some of our preliminary data. So when we look at baseline RNA-seq costs, again, you can compare this to your own centers for those of you that work depending on where you work. And so we looked at one global partner, and we targeted transcriptomics at 100 million reads, which would be kind of the standard that most people use in the US. You can debate, and we'll talk a little bit more about whether that's appropriate or not, but that is what we do. We look through some of the reagent costs, and we look at the US versus that as a baseline as well. And you can see that in our global partner site, it's about $1,700 USD when we convert over to US dollars per sample in that context. And that's using the maximal flow cell. In St. Jude, because in the US, we a lot of times export-import pricing, and in the US, ironically, we get better pricing. You can see that it's about $1,360. For methylation, you can see again the costing, our global partners, it's around $900 per sample. Again, assuming that you're using the Affymetrix appropriately, but it's $900 per sample versus in St. Jude we have about $600 per sample. So these are telling you where our cost thresholds are for some of these next generation sequencing compared to the costs that we had. And again, this is not meant to be comprehensive. Of course, we have more data that we're working through right now, but I feel like these give you some general numbers to see where we are. So basically to tell you, Illumina is just right now too expensive, right? You know, $1,700 for leukemia, $600 for methylation. And so, yes, you can do that in a place like St. Jude or in the US, but can we do that globally? And so we have to think about cost reduction strategies. And when we think about that, there's two different ways one can go about that. You can either really think about improving efficiencies. So that might be like, you know, maybe not doing 100 million reads. Maybe you can get away with a classifier in the pipeline at 50 million or 30 million. And does that allow you to move off of having to use a NovaSeq to a NextSeq or to a MySeq? And what implications does that have for multiplexing versus cost versus whatever? Of course, you can think about doing reflex testing. So maybe taking away some of the depth and then using FISH or something like that for a subset. And then, of course, de-implementing some of the procedures that you currently do. And then there's ways of doing cost savings. So you could do pooled purchasing. So as I mentioned in El Salvador, they have they have leukemia patients, but they don't have that many. So maintaining a flow cytometry lab is very expensive. If they were to use a single platform for solid and for liquid tumors, would that potentially be able to pool their purchasing, or could they work with other hospitals in the region for certain samples like solid tumors where you can ship across boundaries and there's not as fast a turnaround issue? So that's one other issue. Or could they just purchase in a pooled way? Purchase 5 labs, all purchase at the same time, negotiate prices, and then of course they get the shipments to them individually and then they can run them. And then of course there's central level where we do optimization of procedures, you know, what sequencer are you using, etc. And so, you know, thinking about what some of these impacts might have, let's just say that, for example, our global partner utilizes some of the approaches that we use at St. Jude in terms of purchasing. So we know that a lot of times we price some of this stuff out based on research purchasing. And so we don't do bulk orders, we just purchase based on how much we said on the grant that we could do. So one of the things that we could do is, instead of using the purchasing that we do for research, we actually buy more flow cells in the pack and therefore reduce costs that way. This is kind of like a pooled purchasing concept. You can see at using St. Jude approaches, it actually decreases our cost quite a bit. Then for cost efficiency, you know, one of the other questions is around, like, can we go from 100 million to 50 million? And so, yes, that also reduces costs by about 30%. So, you know, if we were able to take that global partner and run more samples on each flow cell, you're able to reduce your per sample costs and have impact. And then, of course, this is the messy table, so I'm not going to ask you to look at it, but you can see that what about actually changing the sequencers that you use? So, you know, using NextSeqs are actually less efficient than using NovaSeqs. Of course, a NovaSeq costs a lot more money. You have to think about all of the upfront, but there are ways to then say that, you know, especially if you can come up with an economic case within your hospital that involves adult cancers or other fields that use genomics, it may be worth investing in a NovaSeq because you can actually make significant reductions in costs. And then, of course, but we had to think about that in the context of, okay, I upgraded from a NextSeq to a NovaSeq, but now I need my turnaround time, and so I'm using flow cells that are half empty in order to meet those. Well, now you're going to double your price or reduce your cost savings quite a bit, because what was a $431 is now $863 because you're basically running, not optimally using your flow cells, and a NovaSeq really is going to help you optimize with multiplexing. Of course, you know, being able to use that 50 million, of course, also makes a difference when we think about different types of technologies that we use. We have to think about, sorry, I'm just going to jump ahead real fast. So we have to think about not just only using one of these. So, for example, if we do nothing, that baseline price of 1,700 that we got from our global partner, for example, or 900 that we got from our global partner, those both are kind of like what the current baseline research level is. But if we were to start to think about better negotiation or improving efficiency or buying a new machine, or potentially creating or seeing if our classifiers can work with lower resolution, each of these come with different savings, so that theoretically, and again, all of this needs validation, could take a $1,700 cost right now down to $400 or something. Same thing, we could do nothing, or we could potentially, through negotiation, increase efficiency, we could potentially get that down to $300. So there's ways to think about some of these costing strategies, recognize we won't get to 400, we won't get to 300, but can we get that 1,700 down to 700? And now all of a sudden it's cost comparative to what we had with the traditional diagnostics, right? And so then we can say, all right, now we have a cost, not necessarily cost benefit, but it's essentially a cost neutral solution. Should we think about switching over to this other, and recognizing that, of course, over time, we know that the cost of genomic sequencing has continued to drop. And so I just want to also highlight that it's a strategy about integrating in potentially, very targeted like diagnostics like FISH and PCR. It doesn't mean that we have to give up on them, right? So let's say that we run the classifier for RNA-seq with at 100 million reads, and that it gets everything that we want. So we spend $1,700, one test gives us everything we want. But let's say that we run that for all patients, and we run it at 50 million reads. But by going to 50 million reads, there are certain subtypes. Let's just say, an important subtype like RUNX1 is not, we don't feel is always captured appropriately if we go down to 50 million reads. So we run everybody at 50 million reads, and then if we don't capture RUNX1 for 50% of patients that we don't that we potentially are concerned about, maybe we run the PCR test. Well, it still means that we're saving a ton of money because we're able to give up some of the classifications by not having the perfect test with everything, and running something as reflex, but it means that we're having major cost savings. And even if you had to run 5 PCR tests, you're still going to have major cost savings. So we have to think creatively about some of these approaches. And so, the other one is thinking about not just Illumina, but ONT, as I highlighted before, as a potential opportunity. And so, ONT, the capital needs can run between 2,000 to 30,000, depending on the type of sequencer, which is an order of magnitude or 2 orders of magnitude cheaper than Illumina. And of course, you can also get around the multiplexing because you can wash and reuse those cells. And so I'm sorry it's so small, but the costs can be as low for some of the settings, like I said, for settings especially where we're just looking at if you don't have access to flow cytometry. So take a setting like El Salvador, where flow cytometry for lineage determination, and that's what they mainly use it for, is really expensive. Well, the cost of doing using a nanopore may be less than $100 in those contexts. And then, of course, the same thing in for adaptive sequencing. So this is where you use DNA on a sample, and you can actually get now more of the genomic subtypes, etc. You can get potentially down to 250. This is all research still, so how these translate into real world is uncertain, but they give you some sense of what the numbers look like. That if you can multiplex between 2 to 4 samples, it's between $250 to $500 per sample. That could potentially give you all of the information, almost all the information as they would get from RNA-seq on Illumina. So is it worth investing in studying this type of technology? I think absolutely. And does that technology have viability even outside of just only giving us incremental? I think absolutely. There's ways to use this moving forward. And of course, I'm going to just, for the sake of time, skip through some of the solid tumor numbers because they look very similar. So if you were to look again at an aggregate, Illumina, you're thinking about $900 to $1,700 currently. There are ways to potentially reduce those costs. ONT are much cheaper, but they may or may not, depending on the future development of some of these. They're not ready for clinical yet in some cases, and where they are ready for at least some type of validation approach, there's still a lot of a learning curve for many labs to learn that, as opposed to Illumina, where many are already working on that. But each one gives a significant saving. You can have significant savings from that. And I just want to make one point here, which is that I said, we can just remove tests and then potentially, or swap out NGS for some of the others. And I just want to highlight that de-implementation is not easy. This figure, which I don't expect you to read, is a process map of all of the steps and all of the discussions that took place for us to remove cytogenetics as a standard of care for ALL once we implemented next generation sequencing through transcriptomics. So basically, this whole process, all of these steps, all of the different pieces, it took over 1.5 years really go ahead and do that. And then, of course, diagnostic testing. We've done this thinking about what we did at St. Jude, and then we talked to others around the world to think about what would that look like. And the bottom line is there's many steps to de-implement a test. You can't just say tomorrow, okay, we're going to stop doing that. So we have to plan for that as well, and that requires a cost consideration too. So, for the sake of time, I'm just going to say that, it's not just only cost. We have to think about cost effectiveness, and cost effectiveness is not straightforward. It requires guidelines. It requires understanding the global burden of disease, or in your context, how many patients are getting diagnosed, surviving, what access looks like, what the risk distribution, what resources they have, the costs that you have, and then, of course, the effectiveness of the treatments that you do. So just to finally, to wrap up, since I wanted to give some time for questions if anybody has any, the bottom line is that right now, Illumina testing prices are probably too high. There are viable options, but we have to think about whether they really translate into the real world or not. No single strategy probably is going to be able to get RNA-seq down alone, and so we have to think about multiple cost reduction strategies for that on the Illumina platform. That there are multiple scenarios, of course, but that all of these require multiple, technical testing and real world testing in order to be able to do this. And of course, we can't just test one scenario. We need to think about all of these different tests as potential ones. And then there may not be one test that meets every global need. So we have to think about what is really appropriate for every context. And that really requires an open and honest discussion based on the data that we have and viable scenarios with all global partners. So I say that because a lot of times the discussions are driven by high-income country investigators, mostly from our research labs, mostly who come without any real global health background. And the thing I would basically say is to hopefully many of you who have more of a lab-based background is that health economics is a science. Health economics brings a research component, and that really you should think about partnering either locally or internationally with colleagues who have a diverse perspective. Because if you don't, what's going to happen is what you do are not going to necessarily translate. And I see a comment in the chat, which I can go ahead and stop sharing my screen actually, and answer. So I showed you costs that are St. Jude costs, but I also showed you costs from one global partner. We have obviously more, but just for the sake of simplicity. So those do reflect real world costs in one country. I can say the country was India, as compared to the US. So with that, I'm open to questions.
Thank you very much, Dr. Bhakta, for that insightful presentation. I think, let me look through the chat. Okay. So somebody's asking, are those costs worldwide or just in the US?
Yeah, so that was what the costs that I showed towards the end were from there. I used the US as a baseline, but so US, for example, RNA-seq, we estimate it's about $1,300 per sample. In parts of the in the other 1,700 came from colleagues in India.
Okay. So if anyone has a question, you can raise your hand and I'll call you, or you can type in the chat and I'll read for Dr. Bhakta to address them. Any questions from anyone?
Yeah, no, thanks, Wafa. So I didn't go into a lot of the work that we're doing just because and I wasn't sure. So what are we doing in this space right now? So first of all, we have two different pathways forward. One is with Illumina-based technologies, and the other one was with ONT. And that ONT is being done together with colleagues at the University of North Carolina and many others around the world. So on the Illumina side, we started work with colleagues in Brazil and in India to really think about, first and foremost, what about the quality of the sequencing data that's being created? So a lot of these, as you can imagine, classifiers are built in CLIA certified labs in the US. And so there was a question about whether we can replicate the depth and the level of sequencing that we need to do. And then, of course, ensure that looking at things like real world turnaround time and the viability of doing that in those settings and doing the costing work. So we're doing that in India for RNA-seq, and in Brazil, we're doing that for some of the methylation work. So Illumina has thus far been focused on those two settings, but we're hoping to expand to additional centers in the very near future on the Illumina side. And of course, think about not just only ALL or methylation for CNS tumors, but more broader tumor subbase. On the ONT side, we've actually moved much faster. So there we have collaborators that are doing active sequencing with Nanopore, and the cost allows us to do this as well as the need. And so we've partnered with colleagues in Pakistan as well as in India, but also and Brazil, but also colleagues in Uganda, in Malawi, and we're hoping to expand our work to working with some great labs in Ghana as well as in Kenya. And so working with all of these and South Africa. And so, what we've seen is that right now, a lot of folks already have a lot of competencies with RNA and DNA extraction. So that's actually been one of the really exciting things, is that there's an infrastructure to build on. And I think a lot of folks in high countries take that for granted. COVID, HIV have really stimulated a massive transformation in diagnostics that we can piggyback on. And so we're just at the beginning of being able to demonstrate that add-on opportunity. But the challenge has thus far just been, we just started this journey really in the last year, and of course, setup time takes time. So getting through your IRBs, getting through data governance boards at a national level, making sure that we get all the training. So we're just getting up and running in a lot of these contexts and are producing our initial data. So that's why I didn't present some of the broader work that we're doing yet, because it's really just starting to become mature.
Okay, so the question Dr. Bhakta just addressed was asked by Dr. Wafa. She asked, can we share any success stories from your work in Sub-Saharan, highlight the potential for transformative change in pediatric oncology? We have a question in the chat from Sherin. The question is, do you think there could be an opportunity to have a cost for sequencing for low and middle income countries?
And the answer is yeah. I mean, and so, like I said, the cost that we had on there was just for India, and I did that for simplicity's sake, but we are collecting cost data from all of those countries and centers that I talked about that we're already working in. And so one of the challenges was that, so here's the one piece, is a lot of people will put costing data into publications that are ostensibly about the science or about the classifiers, and then they'll say like a throwaway sentence, and it cost us $300 to do it. And that's cute, but like a lot of times those costs don't factor in a lot of the real world costs or a lot of the implications of how to actually implement that, or they essentially show only what the costs to the grant were charged, but they don't actually look at the rest of the costs that are kind of subsumed or assumed by the institution. So as a result, you get a lot of noise in the literature right now around costing. So one of the things that we're doing is not just only about producing costing data, but we actually are creating the structures and the frameworks to be able to comprehensively cost out. So the reality is, if you look at in the cancer space, what does it cost to do diagnostics? No one knows. There has been almost no work on how much does it cost to diagnose cancer in any context, especially in low-middle countries. There's been several Lancet commissions on pathology. There's been Lancet commissions on childhood cancer. There's been from the DCP, there's a chapter on this, but almost none of it's informed by real-world data. And no one's actually told us how can we organize that real-world data to give us comprehensive, reproducible, verifiable results. So one of the things that we're working on is actually a methods-based approach. So that way, it doesn't matter where you're sitting, use this approach and you'll at least have an apples-to-apples comparison that's valid for how to cost out what it is in your setting. And then use that, not just for a publication, but actually use that for budget impact, right? Then be able to say to your administrators, okay, so here's the cost benefit or the cost neutrality or the cost deficit that we may have, but here's the added value of the test that we're doing, and then have those discussions, structured discussions with each of your within each of your contexts, talking with administrators, talking with governments as well. So those are kind of the policy implications of this work. So yeah, the answer to the question is there absolutely is an opportunity, and it's something that we're actively working on, and something that we're looking forward to continuing to do. The limited infrastructure So I'm just reading out, Jacob. Sorry, I see the chat, so I was just going to answer Wafa's question. With limited infrastructure, yeah, go ahead.
Yes, so Dr. Wafa has asked another question. With limited infrastructure in many African regions, how can cloud-based genomic tools and platforms be effectively implemented and scaled?
And I think this is a critical question, and it was not easy. So we have developed a cloud-based platform, and we've tested it. So you can actually upload samples in India, run them on a cloud server that's based in Mumbai, and then store them on a server that's based in Hyderabad, and then return results to a pathologist that's sitting in Kolkata. We've set that up so that now it works. So you upload, you run, and you return. And that has major implications. So first of all, like I said, not everybody has an on-premise high performance computing cluster. So that's critical. And we know that in many African regions, access to computing is a major barrier. Internet technologies continue to improve, and I think as we start to see Starlink and all these other satellite-based technologies, reliability will continue to improve even when data cables get cut nefariously overnight. But so I think we're starting to see access to, especially at tertiary care centers, because we're not talking about doing this in the bush. We're talking about doing this mostly at large centers. So we see that the pipelines are there. The ability to do that is there, and the ability to do that, and I highlight that being able to do it all in India, it means that the data localization opportunities are there. So that way, many countries, because of GDPR or HIPAA or because of various other reasons, are implementing very stringent data localization laws. So cloud-based computing can basically be like having an on-premise in your backyard, but running these analyses in a cloud environment. And the other part is it is very cheap. I mean, we're talking about for a large data file for an Illumina-based RNA-seq, it can cost about $10 to $12 of compute time to be able to run and have a comprehensive analysis completed, as opposed to how many millions of dollars are you going to invest in a high-performance computing cluster. And of course, those costs continue to come down over time. So I think this is a no-brainer. The challenge is being able to establish these cloud-based platforms, and it's not as simple as just as putting a classifier into the cloud. I mean, you see some tools like AWS Omics and others that are coming forward, but many of the tools are built for bioinformaticists. They're not built for clinical pathologists or technicians. So there's not good user interfaces. There's the pipelines to be able to set these up and run them in Nextflow packages are not there. So there's a lot of technical pieces that we've had to figure out that are still immature. But the point is that they're doable even today. They're not. It doesn't take a lot of time and effort, but we still need to continue to invest time to study how we can utilize them.
Okay, thank you very much. So there's another question from Adabet Nzenga. It says, why are these diagnosis tests expensive? What is the reason behind?
Yeah, no, that's a great question. So first of all, let's take one that's a standard of care, like flow cytometry, right? So your flow cytometer costs about $200,000 USD, and that's assuming that's a US pricing, right? Of course, you have to pay your export import and may cost more in context. So you can say it's 300,000 or 250 to 300,000. And the reason is because these are not like what you have for HIV, which are 2-color, 4-color, or where in HIV, what they've done is they've kind of created these very, 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 very simple, tools that with a few couple $1,000s because they have one use. It's about CD4, CD8, and that's it. But for us, we have to think about, we need at least 4, 8, or 12 color flow cytometers in order to be able to look at all the different cell lines. And then, of course, you have small numbers. So there's no interest in a place like Becton Dickinson to sell, reagent to a hospital for 60 patients. There's just no economics viability. So they're not going to price that at a good way, and they're going to charge you a premium for that. So there's already going to be markups because each hospital is buying on their own, and then the companies are going to have no interest in investing in it. So there's capital costs. There's the costs that come in with the with reagents that are going to be expensive. Those reagents also have a shelf life, so sometimes there's wastage because you have to buy enough so that if they expire after 2 months or 6 months, you have to buy enough that you can cover the patients but you don't know how many patients you're going to see in those 2 months. You may see 10, you may see 20. So you have to have enough to be able to cover all of them. So that means that some will expire, and you won't be able to use some of those reagents as well. And then on complicating that, of course, is you have to have training, people come and go. You have to worry about a lot of various other issues. So there's a lot that goes into to the human resource as well. So you have capital costs, you have reagent costs, and that's just one test. Remember, that's one out of, you have to think about fish. Sometimes you need 4 or 5 different fish probes because you need to think about different fusions that you're looking for. It's not just one. Childhood cancers are complicated, and we say ALL or BALL, but there's 20 plus different subtypes that have clinical implications among BALL. So that means that you have to have a diagnostic that can comprehensively cover that. So yeah, that hopefully helps you understand a little bit about some of the costing.
Okay, thank you very much. I think we are on top of the hour.
Yes, I do have to leave as well, unfortunately.
Yes. So we are on top of the hour. So Dr. Bhakta, we are most grateful. Thank you very much for the very excellent presentation and insightful answers that you have provided to us for us to understand the economics and genomics of pediatric cancer in low and middle income countries. We are most grateful to all our audience for attending. Thank you very much, and we hope to see you some other time in our meetings. Thank you all for coming.
Thank you.
Thank you, Dr. Bhakta.